All right, let's jump right in and do a high-yield clinical review of scabies. This is a really common condition, but it's one that's also frequently mismanaged, so we're going to break it all down for you.
And just before we dive in, all the credit for this excellent educational material goes to Dr. Mohammed Al-Nagi Mohammed.
Okay, here's our game plan. We'll start with the why and how, the basic science. Then we'll get into what it actually looks like in the clinic, how to treat it, the absolutely crucial patient counseling piece, and we'll finish up with a look at a severe variant called crusted scabies.
All right, first up, etiology and pathophysiology. Let's really get a handle on what's causing this and what's happening in the body.
So the culprit, the little guy causing all the trouble, is this microscopic mite, Sarcoptes scabii. And, this isn't something you get from a quick handshake. It's really all about prolonged skin-to-skin contact, which is exactly why we see it spread so easily within households, among children, and young adults.
And this mite, it's an invader. It doesn't just hang out on the surface of your skin. Nope. It actually tunnels its way right into the stratum corneum, that very top layer of the epidermis, and that's where the female lays her eggs. This burrowing action is really the heart of the problem.
Now, this is probably one of the biggest clinical takeaways you'll get from this. That crazy, intense itch, it's not actually the mite burrowing that causes it. It's a delayed type 4 hypersensitivity reaction to the mites and all their byproducts. Think of it like the body's alarm system finally going off, but it takes about 30 days to ramp up. This lag time is super important because it explains why a patient can be infested for a whole month before they even start feeling that classic miserable itch.
Okay, so we know what's happening under the skin. What are we actually looking for in the clinic? What are the classic telltale signs? You're really looking for a classic trio. First, a really intense, widespread itch, and patients will almost always tell you it's way, way worse at night. Second, you've got the pathognomonic sign, those little linear burrows. And third, you're going to see secondary excoriations, scratch marks all over, because the itching is just relentless.
So where do you look for these burrows? The highest yield spots, the places you absolutely have to check, are the webs between the fingers and the flexor side of the wrist. If you suspect scabies, go straight to those locations.
And here's a huge clinical pearl, especially if you see a lot of kids. In infants, the presentation can be totally different. They can get lesions on their face and scalp, which you almost never see in adults. So remember, in babies, you've got to expand your search.
All right, so you've made the diagnosis. Now what? Let's talk about treatment, the standard protocols.
The guidelines here are pretty straightforward. Your first-line go-to therapy is topical permethrin 5% cream. If that doesn't work, or if there's some kind of contraindication, then you move to your second-line option, which is malathion 0.5% liquid.
Okay, if you remember just one thing about counseling your patient, make it this. The itch is going to stick around for a while. I'm talking 4 to 6 weeks, even after all the mites are dead and gone. This is just the leftover inflammation, that hypersensitivity reaction slowly calming down. You have to set this expectation. Otherwise, they'll be back in your office in a week thinking the treatment failed, and you'll be tempted to retreat them unnecessarily. And that's a perfect lead-in to our next section. Because honestly, writing the prescription is the easy part. The real key to success is solid patient counseling. If you don't get this right, the patient is just going to get reinfested, and the cycle will start all over again. So here are the 3 non-negotiables you have to tell them. 1, everyone in the house and anyone they've had close physical contact with has to be treated at the exact same time. It does not matter if they're itchy or not. Everyone gets treated. 2, the first day of treatment, all their bedding, clothes, and towels need to go into a hot wash. And 3, they need to avoid close physical contact until the whole treatment course is done. And you have to be super clear on how to apply the medication. Tell them, apply it to cool, dry skin. You have to cover your entire body from the neck down and really get into all the creases, between your toes, under your nails, everywhere. Now, some guidelines, like the BNF, even say to include the face and scalp, so be aware of that. For permethrin, you leave it on for 8-12 hours, then wash it off. For malathion, it's a full 24 hours. And here's a key detail. If you wash your hands during that time, you have to reapply the treatment to your hands. And the final critical step, you have to repeat the entire thing exactly 1 week later. This kills any mites that have hatched since the first application. Okay, let's switch gears and talk about something you might not see often, but you absolutely need to know about. It's a severe variant called crusted scabies. Sometimes you'll hear it called Norwegian scabies.
So this is not your run-of-the-mill scabies. This is a hyperinfestation. It happens when a person's immune system is suppressed, so it can't mount that typical response to fight back and control the mite population. We see this in patients with advanced HIV, people on heavy immunosuppressants, or sometimes in the very frail and elderly.
And clinically, it looks completely different. You won't see those neat little burrows. Instead, you'll see these thick, crusted, almost warty-looking patches of skin. And the really alarming part is that these crusts are absolutely loaded with mites. We're talking hundreds of thousands of them. This makes these patients incredibly contagious.
Because of that massive number of mites, just putting cream on the skin isn't gonna cut it. The treatment of choice here is oral ivermectin, and you'll often use it along with a topical agent. And from a public health standpoint, this is a big deal. These patients must be isolated to prevent massive outbreaks, especially in places like hospitals or long-term care facilities.
So, that's our whirlwind tour through the clinical essentials of scabies. We'll leave you with this question to think about in your own practice. We know the treatment works, but the protocol is, well, it's complicated for patients. So how can we, as clinicians, do a better job of helping our patients actually stick to the plan to make sure we're getting rid of this for good?